This recording is going to cover homeostatic mechanisms, specifically looking at the cardiovascular responses to hemorrhage and drops in blood pressure, as well as exercise. In addition, I'm going to look at specific circulations within the body. So what you'll see here is a schematic that shows what would happen if either your blood pressure or your blood volume drops. If blood volume drops, your blood pressure will drop too, because they're kind of linked together. So how we're going to restore homeostasis is very quickly, short term. The nervous system is very good at acting very quickly, and so you'll notice that I have written sympathetics. Now the sympathetic nervous system is going to be activated, and the sympathetic innervation to the heart via the beta-1 adrenergic receptor increases heart rate, cardiac contractility, which increases stroke volume. Both of those would increase cardiac output. So you see that right here. Also, sympathetic innervation to vascular smooth muscle in the arterioles causes vasoconstriction, which helps to increase total peripheral resistance. And remember, mean arterial pressure is equal to cardiac output times total peripheral resistance. So you have sympathetic reflexes that are important in trying to maintain blood pressure and blood volume. Also, you have the release from the adrenal medulla, norepinephrine and epinephrine, which do the same things as if you had that direct innervation by the sympathetic nerve endings. Now, long term, it's a little slower to act, but it lasts a little bit longer, is you do have endocrine responses by the kidneys. Now, the kidneys release renin, and renin leads to that conversion of angiotensinogen to angiotensin 1, which then ultimately is converted to angiotensin 2 by an enzyme called angiotensin converting enzyme. Now, angiotensin 2 has a lot of different functions, and I've only listed a few, but it increases ADH secretion, which actually helps to increase water retention. It's also a vasoconstrictor. Both of those would help to increase blood volume as well as blood pressure. The aldosterone is stimulated by angiotensin 2, and aldosterone, remember, increases sodium reabsorption, and if the parts of the nephron tubule are permeable to water, the increase in sodium reabsorption drives more water coming into across the membrane, and it leads to a little bit more water retention. So again, this would help to increase blood volume, which would help to increase your blood pressure too. Angiotensin 2 also has effects, and specifically within the hypothalamus, which increases thirst. Angiotensin 2 also has effects directly within the kidney, which increases glomerular filtration rate. So it does have a number of different things, but overall, angiotensin 2, by its effects on blood volume, but also I failed to mention is angiotensin 2 is a potent vasoconstrictor that would help to increase your blood pressure and your blood volume. Now, another thing that the kidneys do is they secrete erythropoietin, and the stimulus for that is hypoxia, which would happen if you had insufficient blood pressure or blood volume. And so that would increase red blood cell production. And more red blood cells result in an increase in blood volume. Again, this would help to restore homeostasis. Now, what about what happens with exercise? Well, if we're talking about, say, let's just start with light exercise. A lot of this is repeat of stuff that we've talked about in the past, so it's good review, is when you're, say, just taking a stroll, nice walk, nothing really too strenuous, but you need to increase your cardiac output to deliver oxygen nutrients to those tissues. And, well, you'll have sympathetic stimulation, which helps to increase heart rate. That also will increase your cardiac contractility. So I'll even write that, increases cardiac contractility, which increases stroke volume. This results in an increase in cardiac output, because stroke volume times heart rate is cardiac output. you do have peripheral vasodilation because as you're exercising, you're producing carbon dioxide, your demand for oxygen goes up, and that results in that relaxation of vascular smooth muscle. That results in vasodilation, which increases blood flow back to the heart, which ultimately increases your venous return, plus the addition of your respiratory and your skeletal muscle pumps increases venous return. Now, that increase in venous return will lead to increased cardiac output by way of the Frank-Starling mechanism, by way also of that innate mechanism we call atrial reflex or the atrial stretch. So remember, if you have increased volume in the right atrium, P cells, those pacemaker cells, get stretched, which increases their depolarization rate, which would increase heart rate. Now, that's not a huge increase from resting, but with the you also have the Bainbridge reflex. I'm going to write that down. You also have the Bainbridge reflex, where if you have that increase in volume there, that triggers the sympathetic reflex, which results in an increase in heart rate. And it's about 40% from resting. Now, you also have the Frank-Starling mechanism. With the Frank-Starling mechanism, it's a that increase in volume being returned to the heart results in an increased cardiac contractility, which increases stroke volume. Therefore, cardiac output would go up. Now, the cardiac output's increasing, and so I'm going to do this. Mean arterial pressure is cardiac output times total peripheral resistance. Now, despite the fact you have peripheral vasodilation, which would drop resistance, the increase in cardiac output helps to counteract that. Mean arterial pressure doesn't change all that much during light exercise. Now, what about during strenuous, very intense exercise? Well, you're going to have a much greater sympathetic response. You're going to have the cardiac center, the vasomotor centers, as part of that medulla oblongata, is going to really increase that cardiac output, going to increase total peripheral resistance. That's going to increase, could increase your blood pressure, but I'm going to say it could, but it's actually not. I'm going to tell you why. You do start to restrict blood flow to non-essential organs, the tissues that are working more heavily, more metabolic demand. You're going to have an increased flow to that. Now, your cardiac output is going to increase quite a bit because you have such an increase in venous return. Well, now, why is mean arterial pressure not going to change that much? Is actually because I'm going to write this out. Now, cardiac output's going to increase a lot more. Now, it all depends on what happens to total peripheral resistance. Well, total peripheral resistance will drop. Now, depending on how much it drops, mean arterial pressure may not change all that much, or if anything, it might drop a little bit. And with heavy exercise, you have that peripheral vasodilation, but you also have the effects of temperature regulation, where you're going to have that vasodilation to the blood vessels that serve the skin, which will help you to cool yourselves off. So mean arterial pressure actually could drop and not actually increase during heavy exercise. Now, other thing I want to mention is some specific circulations in the body. Let's look at the brain. Now, the brain is what I refer to as, and I shouldn't say just me, it is referred to as a metabolically controlled circulation. Is certain areas of the brain, you've seen this picture before, depending on what you're doing. So if you're looking at something, seeing words, that occipital lobe, where the visual cortex is going to be more active. And so there'll be more blood flow. So depending on what part of the brain is more active, that's going to have more blood flow. Now, one of the things that I do have to mention is adenosine, which is a vasodilator, is even more potent vasodilator in the brain, because you really want to make sure you have sufficient amount of blood flow in the brain, because if the neurons go without oxygen for a relatively short period of time, you can suffer irreversible brain damage. Now, because of that, we do have a couple different reflexes. They're actually similar but slightly different. I'm going to give you how they're different and how they're similar. Is we have this thing called the CNS Ischemic Response and Cushing reaction. And the CNS Ischemic Response, and this is how like the English spell ischemia, is what happens is if your blood pressure drops too low, and the mean arterial pressure, I believe, and don't quote me, is the mean arterial pressure is got to be less than at least 60 millimeters of mercury. But I think it's maybe a little bit lower than that. But if your blood pressure drops too much, you're not going to get adequate perfusion to the brain. And so it triggers this very powerful reflex, which results in that activation of the vasomotor center, which causes real significant vasoconstriction in all areas of your body in order to, except the brain, where it's going to cause resistance to increase, which would increase your blood pressure to try to make sure that the brain gets perfused with blood. So they call it the CNS ischemic response. So it's a response to ischemia, which would happen if your blood pressure is too low. Well, kind of the Cushing reaction is a special type of CNS ischemic response. The response is the same, but the trigger is different. So with this, the trigger is you have, say, an external compression of a blood vessel. It could be because of, say, increased intracranial tension, maybe too much cerebrospinal fluid, but it also could be a tumor in the brain that's compressing a blood vessel, and it's going to cut off blood supply to the brain. And what that does is it triggers that CNS ischemic response to get blood pressure up to try to force blood through that compressed vessel. So that helps to relieve brain ischemia. So they call that the Cushing reaction. And it's the same, it's named after the same person in which we name Cushing's disease and Cushing's syndrome after. So just so you know, it's the same person. Now the heart is a metabolically controlled circulation. But what's interesting about the heart, one, is cardiac muscle extracts a large percentage of oxygen from the blood, more than other tissues. So if the heart requires more oxygen because it's more metabolically active, it has to be able to do that by increasing blood flow. Now, other tissues, they can get more oxygen two ways. They could either increase blood flow, or first, what they do first is let's take some more oxygen off that hemoglobin that's transporting that oxygen. But with the heart, it already extracts a large percentage of it. So the only way it's going to get its more oxygen is to increase blood flow. Now, the heart does not like to work anaerobically. It wants to make sure it has plenty of oxygen, plenty of blood flow. And what we have is in the heart, another problem that we have in the heart is we have the effects of external compression. So I'm going to show you a picture that shows you coronary blood flow during phases of cardiac cycles. So you'll notice during systole, you have less blood flow than during diastole. Now you have those coronary blood vessels, they have to go down through the muscle, the myocardium, and they can get compressed during that cardiac cycle. And so you'll have a lower amount of blood flow. Does depend on what part of the heart you're in. Is the area of your heart that gets the least amount of blood flow during the cardiac cycle, specifically during systole, is the endocardium in the left ventricle, because pressures are much greater than that. So that actually is the area in your heart that has the higher incidence of myocardial infarctions, because that does get the least amount of blood flow during the cardiac cycle. During diastole, pressures aren't as high, so you see more blood flow during that. But we do have a means of kind of making sure we could try to get more blood flow, especially like in the endocardium, that innermost part of the heart, which is going to be more susceptible to that compression because you kind of compress from top to bottom. But we do have a little bit different receptors in there to ensure that we have a little bit more blood flow, but don't really want to go too far in depth with that. But the muscle, or I should say the blood vessels in the heart will respond to changes in carbon dioxide levels, oxygen levels, by dilating if necessary. Now, the lungs is not a metabolically controlled circulation. In the lungs, it's actually functionally controlled. And I'm going to show you kind of an example of it. Is if the alveoli, which you see right here, where you're going to have the air coming in with the oxygen, and we want the oxygen to go into the blood vessels, and we want the CO2 to go out back into the alveoli. Well, if there's something that happens where the oxygen levels in the alveoli, and it's less than, if it gets below less than 40 millimeters of mercury, that partial pressure of oxygen there, blood vessels around that serve the alveoli will become constricted. And what happens is we refer to as hypoxic pulmonary vasoconstriction. So the vessels that are serving those poorly ventilated alveoli are going to constrict, so we're going to divert blood away from that poorly ventilated part of the lungs. And it's actually a good thing, because if we didn't do that, the oxygen in the blood vessels, say like right here, is typically the partial pressure of oxygen in the alveoli will equilibrate with the oxygen levels in the blood vessels. And so by the time the blood vessel leaves, it's going to be the same partial pressure, be 100. It's not 100. It should be like 104 millimeters of mercury when it leaves. But if the alveoli is poorly ventilated, the partial pressure of oxygen of those blood vessels leaving is going to be low, like you see here, and we don't want that. We're going to divert blood away from that poorly ventilated part of the lungs to where it's better ventilated, so that it's actually a reflex mechanism that helps to maximize gas exchange efficiency. Now, those are pretty much the ones I want to talk about. There's some other circulations, but I do want to show you this picture because it's kind of interesting. Is looking at blood flow in skeletal muscle during different types of exercise. So isometric versus, and dynamic would be isotonic exercise. So if, say, you're doing, we're looking at the legs, and you're doing a static squat, and that's an isometric exercise, you're going to get less blood flow in that muscle during an isometric contraction than if you're doing an isotonic contraction, where if you're doing squats where you're going down and up and down and up and down and up, you'll have better perfusion in those blood vessels serving those legs. So you do have, because of external compression of the vessel during an isometric contraction, you have less blood flow in those muscles than in muscles that are contracting isotonically. Now, what can happen as a result of that is you get what we call a pressure response. Is you have the external compression of the blood vessel. What happens is the tissue's like, hey, I'm not getting my oxygen. I need the oxygen. We need to do something so I can get this oxygen. And so it triggers a reflex action in which the medulla oblongata is going to raise your blood pressure to try to get perfusion to those vessels and those working muscles. And that can raise your blood pressure significantly. So that's a danger of doing isometric exercise, is it could trigger a very large increase in your blood pressure. Isotonic exercise does not do that. So this will be the end of the recording, just looking at some homeostatic mechanisms in regards to the cardiovascular system, as well as special circulations.